Good evening. My name is Michelle Melchiorre, and I'm a practicing physician assistant. Tonight, I'm going to be speaking to you about my doctoral work, actually, from A.T. Still University. I've been blessed to be able to work on a capstone and practicum project that is very near and dear to my heart. I've been practicing for the greater part of a decade in federally qualified community health centers. Very often, my patient population has just tremendous barriers to care. They have Medicaid or they're uninsured. They don't have the money to come to the clinic. There's stigma associated with what they have. Specialists don't take their insurance. They just have never been treated fairly. And they just plain do not, sometimes they just don't understand, the importance of maybe taking their care of things in a preventative state. Often because specialists, there may be a shortage of specialists, so they do not take the insurance. PAs like myself have gone out and become HIV credential, providers. So I am an HIV specialist with the American Academy of HIV Medicine. I've also done extensive training with hepatitis C work. I am Suboxone waivered. I'm proud to say I've got my waiver for 275 patients, and I'm going to encourage each and every one of you to do the same. And in fact, I'm going to share a little bit with you today about the wonderful student loan repayment programs that the United States has in place right now, especially for providers who have their Suboxone waiver. In fact, there are programs now specifically dedicated. Like there's a 6-year program up to $250,000 in loan repayment for those who treat substance abuse. Now, the good news is it's not only just for providers. This extends out to treatment coordinators, care coordinators, social workers, all branches of folks that work within the addiction medicine umbrella. I'm also going to talk to you about telemedicine, which is really offering us this way to remove some of the barriers to care because, my goodness, just in the U.S., we have 2.4 million folks who have Hep C, and almost 50% of them do not know that they have it. So I'm going to ask you to come with me on a journey. We're going to talk a little bit about, it's not really about, the microbiology or the immunology of hepatitis C. This is about how non-specialist providers can step up, learn from wonderful projects like, Project ECHO, or the University of Washington's hepatitis C program, and just what you can do, and to bring this epidemic to a close. We can cure Hep C. Yeah, you read that rote. We can cure hepatitis C. How many times do you see that in medicine? Usually we say we treat something, we try to get it under control. I mean, goodness knows we have trouble getting the common cold under control. So to say cure is a big word. However, our scientists came up with these wonderful direct-acting antivirals that actually kill the hepatitis C virus dead in its track. Now, we found that it's quite effective too. Like 98% of the people who take treatment are cured. This can be a very different experience from those who had hepatitis C back in, from the 60s and the 70s that might have done, interferon and ribavirin and had, just horrible outcomes and side effects with their treatments. Well, today your provider can offer you single pill therapy, 3 pills once a day, 2 months, 3 months treatment. It's up to you. So yes, I said cure. Why can we cure hepatitis C and not HIV or Hep B? Well, hepatitis B, we have a vaccine, a very effective vaccine. And HIV, we have a very effective treatment. In fact, our single pill therapies for HIV have been sort of revolutionary. And we actually know that if you've been virally suppressed for for over 6 months, you can no longer sexually spread HIV to another human being. Think about how drastically different that is from 20 years ago, 10 years ago. My goodness, back to 1987. So this is great. We're on the cutting edge, but we don't yet have a vaccine or a cure. And hopefully one day I'll be doing a presentation talking about how excited I am about the cure. Hepatitis B, absolutely have antivirals that help to manage hepatitis B. And let's just prevent it, which means getting people vaccinated. And if you're not vaccinated and you're watching this, please go out there and get your Hep A and Hep B vaccinations. Hepatitis C, not a vaccine for hepatitis C, but hepatitis C lives in a little bit of a different place. Hepatitis B is a DNA virus that lives in the nucleus, where we kind of all the genetic, engineering and replication, that goes on with our, with the DNA. HIV is a retroRNA virus that also lives in the nucleus. Hepatitis B is an RNA virus that lives in your cytosol, so kind of the goo part of the cell. And it maybe is easier to target and also to kill. So that's just a short explanation. Like I said, by no means a full microbiology, lecture on this, but just like a quickie, quick and dirty version of why this may be the case. Now, the World Health Organization has this as an edict. They would like to eradicate hepatitis from the world by 2030. Now, there's 77 million people today living in the whole of the planet with hepatitis. Hepatitis C and hepatitis B being the prevalent strains of hepatitis that exist. So, is it possible to actually meet these goals? Well, let's see, what their sort of basic, outline of what they want to get done. How does that flesh out? They would like to reduce the incidences of new hepatitis C, of chronic hep C, by 80%. That's a little bit problematic for the United States, where we have, just a tremendous opioid epidemic that is is increasing rather than decreasing. And we're going to talk a little bit about how the new prevalent population has shifted from baby boomers to 20 to 39-year-olds who inject drugs, right? So incident rate, we want to reduce it by 80%. Mortality, because remember, when we don't treat hep C, it can absolutely go on to become cirrhosis and, hepatocellular carcinoma. We want to try to stop that from happening. Diagnosis. We'd like to actually diagnose 90% of the people who are infected. Now, thankfully, the CDC and the United States Preventative Task Force are both in agreement that everybody should be tested from age 17 to 79 at least once for hepatitis C, at least once. Now, if you have other, risk factors, you're in a higher risk population, like say someone who's co-infected with HIV, we want to test them more, but at least everybody should once be tested. So if in your clinic you're not testing yet, please get on the stick. Because if we test, we can treat. Because if we have 50% of the population that has hep C doesn't even know they have it, testing is part of the issue. And then once we treat them, we want to actually get them into treatment. Once they've been tested, we also lose them when we're connecting them to treatment. So where's the U.S. in relationship to these goals of the World Health Organization? You can see we're making a little bit of an inroads in diagnosis. We're not at 50%. Hopefully, if people get behind the Preventative Task Force guidelines and CDC guidelines and tests, then we'll see that increase. We're again making some inroads on treatment and also reduction in mortality once we do get them treated. But here's the problem. Look at that over on the right. Look over here on the right. Problem is we're seeing an increase in incidences rather than a decrease because of the opioid crisis. So if we can get the opioid crisis and hepatitis C treatment, diagnosis and treatment under control, we can help to get better, more on track. There are areas of the country where we are, sort of on target. You can see that there's only 3 states in the U.S. right now who are on target to reach 2030, and that's Washington State, South Carolina, and Connecticut. Now, Washington State is where they actually developed this wonderful 33 CME free. Yes, I said free. You heard me. So if you're a doctor, nurse practitioner, or physician assistant, and you need CMEs, and I know you do, you can get 33 free CMEs just doing the University of Washington protocol. They're on track to reach the goals by 2030. Now, I could make the argument for Connecticut and Washington State because they've expanded their Medicaid. And with the expansion of Medicaid from the Affordable Care Act, that made it much easier for people living with hepatitis C to be treated, also to get their medicine paid for. South Carolina has not expanded Medicaid. I don't know what their secret is. Maybe someone from South Carolina can let me know. You can see that there's a whole nother smattering of the country that may get to those treatment goals by, say, 2031 to 2035. And then there's a whole, the majority of our country, maybe by 2036 to 2040. And then much of the South and the West, we're looking at 2041, to 2049. So we have to come together, and telemedicine and non-specialist providers treating hepatitis C really has the ability to help get the United States on track with the World Health Organization goals. So again, like I said, according to the CDC, we have 2.4 million Americans who are living with hepatitis C, and about 50% of them do not know that they have it. There's a dramatic increase in hepatitis C in our country because of the shifting in the cohort. Used to be the baby boomers, sex, drug, and rock and rolls. Those are who we thought of. Those are who we used to screen for hepatitis C, generally speaking. Now it's 20 to 39-year-old IV drug users of both sexes, female and males. 4 times more new cases of hepatitis C than there were 10 years ago. And again, 4 in 10 people do not know that they have it. We need to change this reality. There's a wonderful article that came out about people who use drugs who are living in the Appalachian region. What we found out is that people that are IV drug users can actually account for up to 70% of the new hepatitis C infections. Hepatitis C infections are anywhere from 10% to 70% of the population, depending on where you are. People living in Appalachia who use drugs have up to 70%, usually around 70% chance of having hepatitis C. And yet they have some of the highest barriers to care. Either there are not clinics, there are not specialists, they do not have insurance that covers treatment for hepatitis C. They live in a state that does not have expanded Medicaid, and they simply do not know how to go about being treated. So if we have this entire population that is at such high risk and it's so highly infected in a virus that is spread by needles, which means that once I have it, if I'm using and I share needles with you, then guess what? You have a greater risk of having hepatitis C. I think about one of the cases that I saw early on in clinic in a federally qualified health center in New York. A young girl and her friends in their 20s, they had a tattoo party. And the girl who hosted the party, her mother, she actually got hepatitis C from her mother through vertical transmission. Because yes, it's a very low incidence, but it is possible for mother to child vertical transmission from pregnancy. So she didn't even know she had hep C. They had a tattoo party, and actually they spread hep C to everybody that came to the party. Now that's what happens, is that you don't know you have it, and then you spread it. So it doesn't need to be someone who injects drugs. It can be from tattoos that were done. It can be from toothbrushing. Do not share your toothbrush with other human beings. Gross. Don't do it. All right. But again, it's important to know that, yes, while IV drug users are sort of the main way that it's spread at this point, it becomes a public health disease that can be spread through vertical transmission, through sexual transmission, through sharing a toothbrush, through sharing needles. If you are, at a tattoo party, so don't share needles. So again, the AASLD tells us that, depending on where you're at, your risk factors go from 10 to 70% of the population, depending on your location and your risk factors. So we absolutely just have to test and treat everyone. Treat everyone. It's not about waiting for them to be sober. It's not waiting for them to be clean, whatever that means. What we find is that people who use drugs have similar outcomes to people in the general population. So if it is in fact the case that people who are still using have similar outcomes, why would we ever withhold treatment? From personal experience, when I first started treating hepatitis C with the direct-acting antivirals, which is when they came out in 2015, there was still a lot of stigma. There was all these, and I was in New York, which, great Medicaid coverage. And even there, they were saying, well, you need to be clean for 6 months. You needed to kind of jump over all of these hurdles before you could be treated. And I fought for treating active users as well as many other people, and it was passed so that we removed those barriers. And I'm happy to say that in most states now, those barriers to care have been removed. And if they haven't been removed still, then we have to really work to get those barriers removed. The American Association for the Study of Liver Disease, the Infectious Disease Society of America, the CDC, and the World Health Organization have all together said, please step out of your comfort zone and learn how to do the simplified treatment protocol for treating treatment-naive adults without cirrhosis. It's time for all of us to do this. Who can. Now, what I have here is the AASLD IDSA hepatic simplified treatment guidelines. And I'm just going to sort of paraphrase them. Again, this is not about how to treat specifically. We can absolutely do another presentation about that, and I would love to do that because, I did help develop the curriculum, for this protocol in my work, which is what I did, for my doctorate. So I'm excited to talk about it. So who is eligible? Adults who have hepatitis C, who are treatment naive, haven't been treated before, who do not have cirrhosis based on a FIB-4 score, and they're not co-infected with HIV or hepatitis B. So used to be back in the day, as they say, I hate that phrase, you'd have to send them for a liver biopsy, or you'd have to have all these complicated tests done, or we'd have to do an ultrasound first to assess for, if there was cancer. We'd do the fibrosis score so we could see through I used to call it the liver jiggle test, to see, how much fibrosis was present. No, all of those guidelines have been removed. A simple FIB-4 will get us the job done. And how do we get a FIB-4? You order a CBC, a complete blood count, and a comprehensive panel. Now that will give us our ALT, our AST, our platelets, and their age. And we calculate from that their level of fibrosis, which has a pretty good, specificity. So that removes barriers to care of even having to order extra labs. If they're treatment naive and they fit this criteria, the good news is that after they're cured, and 98% of them we have shown will be cured, then we just wait 12 weeks after treatment, assess sustained viral response, or if you're cool, you say SVR, and that's what we can call it, a cure, and they do not need further follow-up. So it's not treatment and follow-up for life. It is not. And this is what's amazing, is that it leaves the cirrhotic patients, the patients who need transplants, the patients who are co-infected, to the specialists, to the GI and the hepatologists. And we can alleviate them, because what we know is that in this country, we have about 20,000 specialists who identify. And when you have 4.5 million people who have Hep C, it doesn't take a mathematician or anyone too incredibly brilliant to assess the fact that we have a problem, Houston, and we have to take care of it. So these treatment guidelines make it so that non-specialist providers, be they primary care physicians, physician assistants, nurse practitioners, in an addiction medicine setting, a telehealth setting, a federally qualified community health center, a van at the side of the street in the Bronx, which is where I did it for a while. I have been in so many different treatment modalities, and I can tell you, go to where they are, meet them where they're at, and treat them. And so now what I'm saying is that meet them on their computer and treat them. I'm going to show you how to do that. So how do we treat them? This is why it's become so simple. Used to be, what is their genotypes? The genotype is kind of like the vaccine, the virus's special signature name. And, back when we used interferon, the genotype 1 was the hardest to treat. Genotype 3 was the easiest. Then when the direct-acting antivirals first came out, genotype 1 was the easiest to treat. Genotype 3 became the most problematic. All of that's been alleviated by the fact that we've come up with pan-genotypic direct-acting antivirals. It's a fancy way of saying one pill will treat all the genotypes, so we don't even need to ask for the genotype. And if you were to look on the guidelines for AASLD, genotyping is not even recommended in their guidelines. However, I will tell you that the insurance companies are still a little bit behind with that, and still do get the genotype when you're assessing for them. But we have equal success with all the genotypes. So with either the 3-pill once-a-day regimen with food, or the 1 pill with or without food for pill regimen, it's pan-genotypic for both, which is why it's easier for a non-specialist provider to do this. And we also do not need to have dose adjustment changes for people with kidney disease. So again, it's safe, it's effective, and it's pan-genotypic. These are the treatment options that are available. Like I said, we have the valpatisvir/sofosbuvir, which is 1 pill once a day with or without food for 3 months, or we have the vibitisvir, which is 3 pills once a day with food for 2 months. So it's up to you. So your treatment will be tailored to the patient, and the provider and the patient will decide which is best for them. So how do we address the goals of the World Health Organization, CDC, AASLD, and ADSA? We have to diagnose, link, and treat, treat all in the same place. So if you come to me in my federally qualified community health center in New York City, or you talk to me in a telehealth visit in the addiction medicine practice that I work with, I'm going to identify you. I'm going to diagnose you, and I'm going to treat you in one-stop shopping. And what I'm going to posit to you today is that telemedicine presents a unique opportunity to diagnose and treat in underserved areas for higher risk populations. Is primary care ready to treat Hep C? Thumbs up. Thumbs up. Yes. There's a study here that I'm showing you right now, which was the expansion of hepatitis C treatment in community-based health centers in Washington, D.C., and there was 13 federally qualified community health centers involved, and they utilized nurse practitioners and primary care physicians. And what they found out from this study was that there was actually similar outcomes to specialists. So if you have similar outcome to a liver specialist or GI specialist to treatment, for treatment goals, then why wouldn't we treat? Because the truth of the matter is that as we are pangenotypic, it becomes less problematic, right, to be able to treat. So this study actually showed that, yes, we have similar outcomes to specialists. And how do you get started? Well, aforementioned, the University of Washington has a hepatitis C program. It's online. It's 33 hours. It's CME course. It's self-study at your own pace, and it's free. So that means, for providers, all of us, we need to get 50 credit hours a year. 33 hours goes a long way, baby, to taking care of that. These modules are easy to follow, self-study, and just absolutely full of information that will help you to become more effective and more comfortable in your treatment level. There's also, so this is actually funded by the CDC and the University of Washington. And like I said, it's available on the website that I've included there. The course covers all aspects of treating hepatitis C, so you can actually look at the ones and pick out. You don't have to do all the 6 modules if they do not speak to what you want to learn. I do recommend going through all of them, but some of them deal with advanced disease, but it's important to learn about what advanced disease looks like. There are also wonderful resources for clinicians for many things, for HIV support, for PEP. If you have somebody that comes to you within 72 hours that had an unprotected sexual encounter, we can put them on PEP. We can also put them on PrEP, which can prevent new HIV infections in 95 to 98% of the time when you take it effectively. There's also hepatitis C management. There's also Suboxone help that's available. These consults are free. So these phone numbers are manned by providers that volunteer to help people out that are in the field, be it in community health, telehealth, wherever you are, the van in the Bronx, and they can help you get through your questions that you might have. So this consult line is available to all of us who are out there that want to treat. And again, this is the website where you can actually look into more information. Maybe you want to volunteer to help out on this hotline. Then there's Project Echo. Project Echo was actually developed by Dr. Arora, Dr. Sanjeev Arora. He is a GI specialist, and he lives in New Mexico. And he had a wait list of 8 months to get for his patients to come to see him. And he had a woman who was in her 40s who had Hep C, who by the time she was diagnosed and treated, because took her 5 hours to get to his office, the long waits to get to see him, she died. The treatment outcome was the prognosis and was poor. And so he made a vow that that wasn't going to happen. So he developed a protocol that actually, took specialists where they would have like round type style meetings, that were on the web, where you could actually meet with specialists, go over cases, and learn how to treat. Also, this was a way through telehealth to offer treatment in areas in New Mexico where people did not have access to treatment. Now, when I first started reading about this, even when I first started working on my doctoral program, COVID hadn't happened yet, and telemedicine was so very hard to get reimbursement, and clinics were just simply not willing to go down that road to any extent because couldn't get paid. With the advent of COVID, CMS drastically changed their rules around telehealth. That became our primary mode of delivery through the pandemic. And while nobody wishes this pandemic on anyone, it's helped us to develop telehealth as a major player in delivery of care. Now, the Project Echo is also now, there's models in different countries. In India, where they've taken this and, bless Dr. Arora and his team, they put this out into the world. And for people like me to learn and say, wow, this is something I'm tremendously interested in, and I want to be able to learn how to do this, to bring this to the places where I'm involved. So you can actually look at, their outreach and how to become involved with Project Echo by going on, their website and learning more. And I recommend it. It's fascinating work. Where can we treat hepatitis C? Well, telehealth, federally qualified community health centers, mobile units, substance abuse programs, primary care offices, specialists. Now, 5 out of the 6 places on here, I've treated them personally. You might be able to, brainstorm and think of other places where you can treat as well. But these are, I think, some of the major places where hepatitis C can be treated. So that brings me to my capstone project and practicum at AT Still University. The telehealth model that I worked in was Work at Health. Work at Health is an addiction telehealth, completely telehealth addiction medicine specialty that actually is in several states. They utilize nurse practitioners, physician assistants, primary care physicians, and they work in a telehealth model delivering Suboxone. They also work with, alcohol and other, substance abuse disorders. Wonderful program. I love this. Started working there during the pandemic. And what I noticed right away is that many of my patients had Hep C. At that point, they didn't have a treatment protocol to treat Hep C. And so I was, told to refer out. And after a few referrals out, and my patients were turning to me very dejected, saying that the specialist wouldn't see them because they needed to prove that they were clean for 6 months, knowing, full well that in New Jersey that was not part of, that was eradicated. New Jersey has great coverage for Medicaid. They pay for Hep C treatment. It's very easy to get it approved, and because New Jersey gets it, they want people treated and they want them out there and not giving it to other human beings. So I went to the chief medical officer and the directors of Work at Health, and I presented my proposal of creating a protocol and educational programs based on what they did at Project Echo, using the University of Washington and the ASLD guidelines, and putting that together to create a program. I offered one-to-one coachings. I did pre-recorded webinars, question and answer sessions, and I then, after a year, created a survey to say, how did the providers feel about this? Because nothing was more exciting to me than having people tell me, look, I treated my first patient. And I remember Katie, who was like the first provider, Katie in New Jersey, who had, she was just so excited about wanting to do it. And then I remember when she got her first consult. And then I remember when she did her first treatment. And then when she got her first lab results that showed that the person didn't have hepatitis C anymore. And it's just, she just became just a monster, like a beast, like a warrior of hepatitis C treatment. Or my friend Preet in Ohio, same thing, who, had patients with, all kinds of stuff going on and insurance issues, because we had some things in Ohio to kind of remove barriers to care. And, she just barreled through it. And just to see these providers blossom through this telehealth addiction medicine format that was laid out by using the guidelines and just really the protocols that were put into place by these various organizations. So this is just sort of the age distribution of the people who were treating it. And you can see that, most people were within 35 to 44 years of age, and most identified as female. I certainly offered people to identify as non-binary, but basically got male and female. Vast majority were female. And, we had a pretty good smattering of different, people who identified as white, African American, American Indian, and Asian. So very, I think, a good distribution of people who were, providing the treatment. And we had representatives from several states. As I said, Work at Health has clinics, telehealth clinics in many states. So we have Michigan, New Jersey, Texas, Ohio, California, Alaska, Florida, and Oregon. And I'm sure even as I do this at this presentation, that list has increased. This is fascinating. 69% of the providers had never treated hepatitis C before the training protocol. So that means they were hearing me, give this call to treatment just like you are now, and 69% of them had never treated. Experienced providers for sure, but just gave them the tools in which they could treat. This was kind of their comfort levels before and after treating hepatitis C, and you can see on the left that 20% of my folks were either very uncomfortable, and 26% were uncomfortable, and 26% were pretty neutral about treating, and really only 13% were either comfortable or very comfortable in treating before we got started. So not a lot of comfort before But, after doing the pre-recorded, webinars, doing the University of Washington protocol, working with me with one-on-one coaching and the question and answer sessions, you could see that after they completed it, almost 47% of them felt that they were comfortable with treating hepatitis C. The simplified version of hepatitis C. And almost 30% were somewhat in the ballpark of wanting to do this, which went, I feel like the pendulum really shifted, and that just warmed my heart to see that change. I asked them a question in the survey, like the process of treating hepatitis C with labs, medication, follow-up support was easily followed by the protocols. And you can see that the vast majority of them agreed. They strongly agreed, in fact, that the process was easy. It was easy to follow. So if you put into place the protocol and you teach them, people can learn, right? We do all kinds of certifications through our medical careers. We're always learning and growing. So I designed this particular protocol so that it can easily be replicated in different environments, and I encourage people to do that. And certainly, if they want some help with that, you can certainly reach out to me to do the same. This was what was fascinating to me, is that there's actually more people that have been treated than they've reported to me. So while I don't have the exact numbers on this, because I haven't had the follow-up, I'm finding that, my goodness, they've taken this ball and sort of run with it, and we're treating. People are treating Hep C. So those are some. Thank you for letting me share just some of that information with you, and I hope that makes sense. I'm going to ask you to also think about making a decision to treat opioid addiction because of this epidemic and the amount of overdoses and fentanyl, and it's staggering. It's scary. And treating with Suboxone is a fabulous treatment. It's a medication that does not get people high. It's a partial agonist, not a full agonist, which full agonist like heroin goes like this, like methadone. Suboxone is here. Buprenorphine is like this. It's a partial agonist, so we can block that same receptor, that mu receptor, but we do not get high. Also means we have a very difficult time overdosing on it as well, which is also what can happen when you're taking something like methadone. So the quality of life is fantastic, and if you're doing this in a telehealth model, then patients do not have to have the stigma of going into a clinic. And telehealth rules support addiction treatment in a telehealth model as well, because this makes it easier for the patient. So why should you complete the training and get what we call your DATA 2000 waiver? The maximum waiver right now is 275. The rules right now are that actually the first 30 patients, we don't even need a waiver, because that's how bad it is out there with the opioid addiction. So people in the ER can start people on Suboxone, and we have to link them to care. And first 30 patients, we don't need that documentation yet. But I encourage you to reach out, because actually, one thing that happens when you get your waiver is you become priority for the National Student Loan Repayment programs. So actually having your waiver puts you at like a higher level for qualifying for getting a student loan repayment, and having your waiver actually entitles you to apply even for separate loan repayment programs that have been created for addiction medicine providers. So think about that. So it's a big deal. And the programs are offered generally through either, you can go through like AAPA, our PA Society offered the 24-hour trainings free of charge for PAs. I'm sure nurse practitioner, provided training associations exist as well. Department of Health often offer, this MAT training. We call it MAT, medication assisted treatment. They offer them free as well. For physicians, MDs and DOs, it's 8 hours of training, 4 in person, 4 online. For nurse practitioners and physician assistants, it's actually 24 hours of training with, again, the first 4 hours being in person. So you can reach out, like you can actually Google health department and MOUD training, and you will come up with many resources for where you can get trained. And again, it's actually wonderful training. I mean, I know for nurses, practitioners and physician assistants sounds like a lot, but the extra hours are like training in, just psychology and psych meds and just, I think, alcohol addiction. So it's really a comprehensive training. And so I recommend it in all cases. And again, your CMEs. So, if you do your University of Washington free CME for 33 hours and you do this for 24 hours, my goodness, you've, almost taken care of your entire, well, you have taken care of your, your 2-year commitment that you need, for your CMEs. Which loan repayment is right for you? Well, here's just a HRSA Service Corps sort of summary. There's the good old-fashioned National Student Loan Repayment Program, and that's 2 years, and it can be $50,000 for full-time and $25,000 for part-time. And again, if you have a Suboxone waiver, that's going to put you in a higher bracket to get accepted. However, there's a program called the Substance Abuse Workforce Loan Repayment Program that actually gives you a little cookie there for having your waiver. So you get $75,000, for full-time and $37,500 for part-time for 3 years. So it's more money. So having your waiver gets you more student loan repayment. And remember, you can actually re-up these programs when you're finished with them. And then they have, if you're going to do Suboxone and you're willing to go work in a rural or underserved community, it could be $100,000 for 3 years, or $50,000, for full-time, for $50,000 for part-time. I kid you not. So if you find a community health center or an Indian health center in a rural area, you could qualify for $100,000 in your student loan repayments. Now, you might be asking, well, what if I'm an international medical school graduate? It doesn't matter. You have to have a practicing United States license, right? So it's not about the med school. So I'm not talking about medical school program repayment. I'm talking about, after you get out and you're in the workforce repaying, not during medical school. So even if you're, when you are a graduate, if you are, a graduate from a Caribbean school, from a school from a different country, once you have your U.S. license, you can apply for, these programs. Now, this is a special program which is called the STAR LRP, and this program itself actually splays out to the other healthcare workers besides just the doctors, physician assistants, and nurse practitioners. This actually includes all of the specialties that are listed. And, as you can see on here, there's nurses, midwives, there's therapists, counselors, social workers, peer recovery specialists, case managers, health navigators. Now, this is a 6-year full-time service commitment, and it's up to $250,000 in eligible loans. Now, I don't know the specifics if it's based on whether you are the provider or the part of the team, but there's just tremendous amount of money available for loan repayment because the addiction crisis is so intense at this moment. So if you have it in your heart, you want to learn more, please reach out. And these are just some final thoughts for me. Hepatitis C is a public health concern. Absolutely. Every person we treat is one person less that can infect another human being. So when you think about it from that perspective, it just becomes another, edict for us to treat, right? Because public health is everyone's health. And with simplified treatment, non-specialists in primary care can safely take care of patients and contribute to the World Health Organization goals of ending hepatitis by 2030. Telemedicine is an effective way to treat hepatitis C, especially in programs that treat substance abuse. And you can do it. There's resources that are available for training, coaching, and and just free support whenever you need it. And plenty of resources for getting your DATA 2000 waiver to not only treat patients, but to help you repay your student loans. Yay! So again, if you have any final questions or thoughts, you can reach out to me. You can find me at A as in Apple, M as in Michelle, M as in Michelle, A as in Apple, PA12@gmail.com. That's Michelle. I'm a PA at PA12. And I wish you great success in everything that you do. And thank you so much for listening to me. Goodbye for now.